I have no financial relationships to disclose. This is kind of an interesting topic to talk about this year because this is the year that we'll be updating the resuscitation guidelines. So rather than go through the guidelines of what you should do, which will be up to date next year, we're going to come back to Sol Shnider and hear the 2015 guidelines presented. I thought I'd go back and sort of think through the physiology and what you should be doing for airway management. So my goals are to just give you kind of the two key differences to remember between maternal and non-maternal CPR, and to set priorities for breathing and airway management, and then understand interactions between airway, breathing, and circulation during CPR, considering maternal physiology and the impact that may have. These are the 2010 guidelines. Again, these are going to be updated coming out in October issue of Circulation. And I'll tell you, over the past year, hundreds of evidence reviewers have been tackling over 300 topics related to resuscitation science using this GRADE methodology to come up with an international consensus on science and treatment recommendations for each of the topics. And those are currently all compiled. They were presented in Dallas in the beginning of February, and the writing groups are synthesizing them into the ILCOR document. ILCOR was created in 1992 as a liaison between all of the resuscitation organizations around the world. And they sort of undertake this evidence review process to establish an international consensus on what the evidence shows. And then each of the regional organizations, including American Heart Association, will take that science and bring it together with knowledge about their population, resources, infrastructure, training systems, in order to come up with specific guidelines for what to do for that country. So you'll see these come out together, and that's how they fit together. There is some recommendations to draw from that are recent. This is from the SOAP consensus statement on maternal CPR that was published in 2014. And so I'm going to draw on this because our working group came up with what we thought were some reasonable airway recommendations. But I'm going to reflect on some additional reading that I've done and how I might change what we recommended in this document. There'll be another document that is very similar to the SOAP consensus statement, but about twice as long, summarizing the scientific statement from the American Heart Association on cardiac arrest in pregnancy. And we can expect this one hopefully next summer. So in a nutshell, if you had to say it in one sentence or less, what's the difference between obstetric and non-obstetric CPR? And the answer is it's pretty much high-quality CPR with the addition of uterine displacement and delivery. And I think pregnant women are special, but they don't need special CPR. And that's probably the one message to take home here. If you want to know more details about how to get it done, how to get your teams ready, how to be sure everybody knows the rules, and we actually can execute high-quality CPR on the LNG unit where it never happens, and get the baby delivered and everything else that needs to be done, I would recommend the lectures that have been given by prior Sol Shnider meetings, particularly the one by Steve Lippman from 2014. But I'm going to focus on airway management, and this is an area where there's basically no evidence, and when there's no evidence, we kind of fall back onto talking about physiologic principles. And so what I'm going to do is just zip through the physiologic changes of pregnancy as they pertain to the cardiovascular system and the respiratory system, and think about what the implications are for when the heart stops. So oxygen consumption increases in pregnancy 20% at rest. And it turns out that that's the exact same difference that you see when all of us non-pregnant people change from the supine to the sitting position. Cardiac output or oxygen consumption increases from 2.8 mils per kilo per minute to 3.5. And that's about what it is in a pregnant woman in the lateral decubitus position. Of course, it'll increase further when she's in labor, when she's certainly during the second stage of labor, but just your arrested pregnant woman who is not doing anything is going to have an oxygen consumption that's not particularly that much higher. The physiologic adaptation of pregnancy are largely able to accomplish that increased oxygen delivery with ease and with a great degree of extra oxygen delivery. And so the extraction ratios actually fall as pregnancy progresses. A couple of things happen. You have expansion of plasma volume, a little bit more than the expansion of the red cell mass, and as a result, there's a physiologic anemia of pregnancy. That's helpful because it decreases the viscosity of the blood and it decreases the workload to push the blood around the body, and so you can have an easier increase in cardiac output, and that'll go up really right at the beginning of pregnancy as shown here, and then 50% by the end of the third trimester. In the supine position, the increase is really only 30%, but remember I said there's actually a buffer, a tremendous buffer, because oxygen delivery is increased more than oxygen demand. What's going on in the lungs? Well, the two big things are increased minute ventilation, which is driven primarily by an increase in tidal volume, with no change essentially in the respiratory rate. So when we think about our ventilation rate during CPR, I don't think we need to be doing much with that. I think we can do standard BLS and ACLS. There's a little bit of expansion of the bronchial alveoli, and so there's more physiologic dead space, so maybe dead space ventilation will go up a little bit, but you're going to have dead space ventilation when the cardiac output falls down, just by definition. Functional residual capacity decreases 20% in the upright position, 30% in the supine position. So that's going to be a real difference that will persist in your arrested patient. Pregnant women have what's called a barrel chest. At the very beginning of pregnancy, it's noted that the ribs will flare out even before the diaphragm pushes them up. And that's a function they think of relaxin, which changes the angle of the ribs on the sternum and increases the AP diameter by 2 centimeters, the transverse diameter by 2 centimeters. And so with this barrel chest, the increased work of breathing is from diaphragmatic excursion, less from chest wall excursion because there's less capacity there. But thinking about CPR, I think we have more room to think about chest compression depth and also hopefully better chest recoil with release of the chest compressions. And of course, PaCO2 falls with the increasing minute ventilation and as a compensatory factor, the kidneys will start releasing or decreasing the sodium bicarbonate, bicarb, and that will decrease the buffering capacity of the blood. So in theory, she'll be less likely to tolerate acidotic conditions. In fact, I think, when you think about the oxygen hemoglobin dissociation curve, that additional acidosis is physiologic in that it will help to remove oxygen molecules from the hemoglobin and delivering them to the acidotic tissues. And I'm going to talk a little bit more about that in a minute. But first, I think we as anesthesiologists, anesthesia providers, are really encountering pregnant women, and we're thinking about this in terms of our induction of general anesthesia. And in that circumstance, those ladies have a spontaneous circulation, and we briefly interrupt ventilation in order to secure their airway. So we're very attuned to this issue that pregnant women have a shortened duration of apnea before they start to desaturate. But flip the script in cardiac arrest, what you're dealing with is no cardiac output, and you can ventilate all you want. It's not going to impact cardiac output, or it's not going to impact oxygen delivery. This particular figure is a simulation study where they programmed in physiologic variables to come up and use standard physiologic equations to come up with the duration of apnea before desaturation. They programmed in 100% oxygen into the FRC, and what I want you to note is that on the far left of the figure is BMI of 50 in labor. Well, that lady's going to have the biggest cardiac output, oxygen demand will be higher, and the lowest FRC. On the far right is the woman with preeclampsia who has the lowest cardiac output, probably has a moderately decreased oxygen consumption FRC. So the biggest gap between those two on that whole figure is really driven by cardiac output. Cardiac output falls, oxygen consumption falls. So let's trace a molecule of oxygen from the trachea out to the cell. First step is alveolar ventilation, and as we all know, the bulk of it is initially provided by convection, breathing. Well, breathing drives oxygen molecules out to about the 14th generation of the bronchial tree, and beyond that, most of these molecules are moving by diffusion. And there is data from non-obstetric patients that I'm sure all of you know that if you maintain a patent airway and insufflate oxygen, you're able to move oxygen from the trachea to the alveoli just by passive diffusion. And so I think when we're getting into cardiac arrest situations, that's a tactic that we should keep in the back of our mind. Second step is alveolar respiration, which is moving oxygen from the alveoli to the pulmonary capillaries and loading it onto the hemoglobin. And for that, you need a little bit of oxygen in the alveoli. You need a patent alveoli. Atelectasis will destroy this. And then you need blood flow through the capillary running next to the alveoli. And to get blood flow, you need cardiac output. And the more intrathoracic pressure that you're applying in order to inflate those alveoli, the less cardiac output. And there's a little more to say about the oxygen dissociation curve that you'll see in a minute. Oxygen transport is, the equation for that is cardiac output times the oxygen concentration of blood, which is primarily how much oxygen is loaded onto the hemoglobin, but that's driven again by cardiac output. And then the final thing to think about is how those cells are pulling oxygen out of the blood, and that's really thought about in terms of the oxygen extraction ratio, which is the ratio of oxygen utilization over the delivered oxygen. Overall, it's about 25%, so there's quite a bit of reserve, but there's less reserve in the heart and in the brain. But I think, again, the hemoglobin helps this a little bit because pregnant women have increased 2,3-DPG, which shifts the curve to the right. Now, if you go to Wikipedia on the same site, it'll give two different curves, and I spent a lot of time trying to figure out which one of these is actually correct. You can see the curve on the left, the sigmoidal curve correlating PaO2 on the x-axis with oxyhemoglobin saturation on the y-axis. The whole curve is shifted to the right, including at the very apex of the curve, such that at a PaO2 of 100, the hemoglobin is illustrated as having about a 90% saturation. So is that right, or is the curve on the left, or on the right correct, that the two at the top kind of converge? There's a lot of reading trying to figure that one out, and I think from the exercise physiology literature, it appears that the curve on the left is correct, that in the lungs, if your PaO2 is about 100, you will have just a little bit lower oxygen saturation if that hemoglobin is loaded with 2,3-DPG. But when we think about it, okay, if the oxygen, or if the hemoglobin is saturated with 90% versus 100%, how much oxygen are we talking about? It's 10% of the total carrying capacity. Contrast that with the benefit out in the periphery by shifting that hemoglobin saturation curve to the right. That hemoglobin will be more facile at offloading oxygen, and furthermore, there's a further shift to the right with increasing acidosis. So it's not that the hemoglobin just follows up and down this curve as it circulates around the body. When it gets out to the periphery, it's even further to the right, and so the heart cells, the acidotic tissues are able to pull off even more oxygen. And so from the exercise physiology literature, 2,3-DPG helps preserve oxygen cardiac function at very high workloads. This is just going back to the delivery equation. I'm just showing you that cardiac output is the real driver here. And I plugged in a few numbers. The first line is numbers you'd see in a non-pregnant person. Increasing your cardiac output 50% takes you up to 7.5 liters per minute. Adjusted the hemoglobin, and you can see overall we're talking about a 30% increase in oxygen delivery. But then the line below, I really just highlight out the big drivers here are cardiac output and oxygen saturation. So really, as long as the hemoglobin is fully saturated, additional oxygenation has minimal impact on oxygen carried, and so the driver for delivery is cardiac output. There's a bunch of these studies. I chose this one really because I thought the title was provocative. It's called Death by Hyperventilation. And what this is, that this group followed firemen out on their resuscitation calls, and they were observing these firemen ventilating patients at rates of 30 to 40 breaths per minute, just really quick. And they felt that this was really hazardous, but couldn't find great data, so they went back into their lab, and they did this pig physiology study, and anesthetized, intubated the pigs, and did chest compressions and ventilated them using 12 breaths per minute, 20 or 30. And you can see the decrement in coronary perfusion pressure. And that is correlated with the increase in intrathoracic pressure as a result of the increasing rate of ventilation. They're overventilating. At the bottom, you see the PaCO2 is driven down to 11 with that hyperventilation. PaO2, even at a rate of 12, is way higher than it needs to be. Survival is impacted by this. So the pigs ventilated at 12 had a survival of 85% versus 5-10% with a rate of 30. Even when they add back in carbon dioxide, survival rate is still poor. So it's not the hypoventilation that's causing harm, it's the increased thoracic pressure and increased respiratory rate. So with all of that sort of physiologic background, I'm going to go through some airway management choices and just basically give what's in the guidelines and what my recommendations are based on that kind of reflection. So in 2010, AHA started recommending hands-only CPR for lay rescuers out in the community, and it was based on a series of 3 trials that randomized to either standard BLS or hands-only CPR, and survival was better in all 3 studies using hands-only CPR. And it's pretty clear it's because lay rescuers don't want to do mouth-to-mouth. They're not very good at it. It takes a long time, and it interferes with chest compressions. Number 2, with cardiac etiologies of rest, blood retains some oxygen for several minutes. And number 3, even with hands-only CPR, there's some evidence that there's gas exchange, a minimal amount that is enough to at least contribute to oxygenation. But trained rescuers hopefully should be able to ventilate effectively, and with effective and rapid ventilation that minimally interferes with chest compression, outcomes are best with a 30-to-2 compression to ventilation ratio. And I think this is what we should be aiming for the initial airway management in pregnancy. They also introduced the switch from ABC to CAB, and a little bit of concern with that. Well, with pregnant women, they may be more likely to have respiratory etiologies of arrest, and they're more likely to need ventilation. Basically, the bottom line is CAB is just way more efficient to get things started. If the first, and think about it, if there's a whole bunch of responders, the first person that arrives, if all they have to do is do the pulse check and then start chest compressions, they can get that going immediately. Meanwhile, a second person that arrives can open the airway, get the face mask, get the equipment set up, and start managing the airway, and so then they're ready to give their ventilations at the end of 30 chest compressions. The other concern is, well, maybe the pregnant ladies have a higher rate of respiratory arrest, and we really need to oxygenate that blood quickly. So we can answer that based on this analysis of administrative data in the United States. We queried the nationwide inpatient sample for, 14 years, and identified almost 5,000 arrests and 56 million deliveries. So huge study, a lot of power. And what we found is an event rate of 1 in 12,000. Most common etiologies of arrest, though, were not respiratory. They were hemorrhage, cardiac, AFE, and sepsis. And then if we think about looking at this list, which of these might be a respiratory etiology, anesthesia complications, aspiration pneumonitis, eclampsia, and so on, and you add all of those up, it's maybe 20% of the total. So most of these are primarily cardiac arrests. If you're going to ventilate, do a good job. That's illustrated by this study, which is an observational design where they looked at 105 resuscitations, and in this case, bag valve mask by itself is the referent. If you add an airway adjuvant, it increases the probability of good neurologic outcome 3.5-fold. And intubation, turns out, decreases the probability of good neurologic outcome, and that is a consistent finding, and I'm going to show you that a little bit more in a minute. What should we be training our rescuers to use to get their face mask ventilation? Whole bunch of studies suggest two-handed ventilation is more effective than one-handed. Should we be using this C technique or the thenar eminence technique? This study recruited volunteers undergoing elective anesthesia and novice resuscitators. They induced anesthesia without muscular blockade, hooked the patients up to the ventilator so they could measure expired flow, and asked the novices to hold the face mask, either using the C or the thenar eminence technique. And their finding was basically that the thenar eminence technique is just a little bit more reliable. And so I think this is probably the technique of choice to teach our primary rescuers, but certainly C worked quite well and better than single-hand mask ventilation techniques. So in summary, for BLS, compression to ventilation ratio of 30:2 stands. There's some debate whether we should be using 100% oxygen to resuscitate, but I think that's reasonable at this point. The person who's managing the airway will arrive, open the airway, steal the face mask, and maintain a patent airway throughout chest compressions. So does advanced airway management, intubation or supraglottic airway insertion, improve outcomes? And this is the data is primarily coming in from out-of-hospital cardiac arrest, and in that context, there are huge numbers coming in from a series of observational studies, primarily in Asia, and for the most part, the answer is no. That if the referent on this slide is bag valve mask ventilation, the likelihood of neurologically intact survival is reduced, both with intubation as well as supraglottic airway insertion. Could be a lot of confounders going on here. People who have rapid return of spontaneous circulation aren't going to have time for advanced airway management, and it's unclear if this is causal or just an association. And so there's a randomized trial ongoing now to try and answer that question. But I bring it up because I want to reassure everybody in the room that getting the breathing tube in the person's trachea is not going to be the factor that will save their life. And intubation can be difficult, and that's true historically, but even in most recent reports. This is a SOAP SCORE project, and they report a failed intubation rate of 1 in 500 in pregnancy, 0 aspirations. In Australia and New Zealand, they report an incidence of 1 in 270, 8 regurgitations, but only 1 aspiration. She survived. UK obstetric surveillance system, 101 in 122 failed intubations, most rescued with an LMA. They also had a couple cases of gastric aspiration. All of them survived. But on top of that, be aware that any arrested patient is going to have a higher risk of difficult intubation. This is data we collected at University of Michigan, and the difficult intubation rate there was 10%. And the risk of failed intubation was 1 in 180, most of them rescued with an LMA. So I think you put pregnancy together with cardiac arrest, and you're looking at a pretty sizable failed intubation rate. And so the question is, what are you going to do? And I think we can turn to the SOAP consensus statement and kind of pull from there what are the steps. And so they recommend a ventilation strategy that I just described. And then when you arrive at the scene, you don't want to just jump right in and try and get your breathing tube in. It's important to spend a little bit of time to set up the portable suction and airway equipment. You want to set up your primary intubation techniques, your rescue techniques. Don't interrupt chest compressions. Probably want to position your airway equipment in the mouth while chest compressions are ongoing so that you can really minimize the pause between when you obtain your laryngoscopic view and get the patient intubated. The SOAP consensus document suggests a secondary attempt. So if the first attempt is with a DL, the second might be with video laryngoscopy or vice versa. Having seen all this observational data, I'm not sure now. I'm not sure if a second intubation attempt is really worthwhile or if you should go right away to supraglottic airway insertion. I think you could do either one. If supraglottic airway ventilation is not working, and it's perfectly reasonable to go right back to face mask ventilation, get the baby delivered, hopefully move on to return of spontaneous circulation, and then redress the airway at that point. Once the airway is controlled, recommending just standard ventilation, 10 breaths per minute, a tidal volume between 500 and 7 mils per breath. I'm coming up on the end of the talk and had a few more slides to go over quantitative capnography. It's recommended as a tool to an indirect measure of cardiac output in the 2010 guidelines. I anticipate that those recommendations will be strengthened in the 2015 guidelines, and you'll likely come to see these tools on your code carts in the future. And so there's handheld capnographic devices. There's this one by Massimo that goes in the airway. And then a lot of the defibrillators are now incorporating capnography on their machines. Capnography can be helpful, again, for assessing the quality of CPR. This is a big observational study where they correlated depth of chest compression with end-tidal CO2 and showed a direct relationship between depth. At the same time, no relationship with the rate, if the rate is between 90 and 130 beats per minute. So that's also potentially going to change some science. Your primary variable in quality chest compressions turns out probably to be depth. I'm going to skip through these. These are novel ventilation strategies to improve perfusion, and just come to my conclusions. So once again, recommending a ventilation to compression ratio that is the same as for non-obstetric patients, but really emphasizing that you want to do what you can to entrain oxygen during chest compressions. And then for advanced airway management, it's important to minimize the pause in chest compressions. Anticipate a difficult intubation. If you can't intubate, move on to the next strategy, because there's no evidence of improved survival with intubation. And the most important thing, I think, is to avoid persistent attempts to intubate, both because of the increase in airway swelling, but also because of interruption in cardiac output. And finally, to anticipate capnography in your hospital.